Good evening, ladies and gentlemen, distinguished guests and speakers, professors, doctors, and also our fellow colleagues. First of all, greatest appreciation to our organizing committee members and also our collaborators, especially from the REBUNG Cancer Care and Primary Care Team, University Malaya, and also University Malaya Medical Center, Project EcoZoom, Majlis Perbandaran Petaling Jaya, NDPJ, ACADMED, MMA, FMSA, AFTM, and also PKB40. I would like to extend a very warm welcome to all of you to the soft launch REBUNG Cancer Care in Primary Care short course. I am Dr. Hadis, Medical Officer from UMC, who will be chairing the webinar today. So today's webinar is about early detection, save life. The Malaysian Ministry of Health, KKM, reported about 11% of cancer cases from 2012 to 2016. Cancer death are the leading cause of death in private hospital, which is about 34.9%, and the fourth leading cause of death in KKM hospital, which is about 12%. Cancer screening tests can assist in the detection of cancer at the early stage before symptoms appear. So who should undergo the screening test and how has the screening test been performed? So tonight, we already invited several esteemed speakers who are expert in their field to share some latest insight in cancer screening or detection, especially in prostate cancer and lung cancer. So the objective of our program today are to introduce the REBUNG Cancer Care and Primary Care short course to primary care providers, to update the standard guideline for cancer screening, and also to highlight issues related with tumor markers. We hope that you will find our program most engaging and insightful. Before we begin our panel discussion session, I would like to welcome Prof. Nur Aisyah Muhammad Taib to introduce to us about the overview of REBUNG 2.0 project. Prof. Aisyah is no stranger to surgical fraternity who has expanded the field of breast surgery over the years. She is currently a senior consultant breast surgeon in University Malaya who has deep knowledge in cancer health system in Malaysia and breast cancer survivorship. She is the principal investigator of REBUNG Project 2.0 and director of Cancer Research Institute, University Malaya. Please welcome Prof. Aisyah.
Thank you, Hanis. I think I need to share my slides. So hopefully we can move on. Okay. All right. Are you able to see my slides?
Yes, can Prof?
Okay. All right. Okay. So good evening, everybody. Thank you so much for making it to this webinar. I'm Nur Aisyah. I'm actually the primary investigator of the REBUNG project, which is really reducing cancer early diagnosis barriers in the urban B40 group. And we are specifically looking into Selangor. So REBUNG is made up of multiple partners and researchers and multiple stakeholders. So we have almost like 10 team who are leading in their own programs. And we also have a large group of UMMC cancer education professionals who are really teachers and doctors, specialists and consultants working in our hospital. So we really need to reduce this cancer late diagnosis, as we all know, and we know there is a lot of low health literacy among committee members, leaders, healthcare providers, and this is really the main barrier. And we know we have low cancer survival rates, and we know that we are all functioning in silos. So REBUNG is really putting forward evidence-based interventions and implementing it into communities in a pilot project. So we have gone to REBUNG 1.0, which we have successfully completed in Taman Medan, and now we are in REBUNG 2.0. So the evidence-based intervention that we know is actually creating optimal care pathways to cancer early diagnosis and really collaborating with the different stakeholders to make it happen. And we know by putting forward health promotion, which is framework-driven through strategic communication campaigns, we hope to improve the literacy and improve the outcome of our cancer patients. So really what we are doing is trying to sustain an optimal care pathway through the Ministry of Health Klinik Kesihatan, as well as the private general practitioner clinics. And we would like to digitalize the information that we provide to the community as well as the optimal care pathway. And we are in collaboration at the moment with Sri Lanka. And we will be conducting community campaigns on health literacy. So we have produced multiple modules and training modules as well as materials for community campaign for REBUNG in Taman Medan. And now we are about to embark in another location where we will be translating all our information into Mandarin, English, and Tamil. Before this, all our materials have been produced in Malay. So we have actually obtained about very impactful outcomes in terms of improving D40 screening in mammogram screening, where we found that 68.3% of our patients who attend KK Taman Medan who were invited for screening actually completed the mammogram screening in a private facility. So just to share with you, we have materials that you can use for your own patients and for your own like family members. You can find us on YouTube. You can type out YouTube REBUNG and it should write cancer, or else you get all the recipes. What we have is about 14 videos that will explain about symptomatology of the 4 top cancers, as well as how a diagnosis is made and what will happen, what of optimal care pathway is available for these committee members. So it is really a multi-sector collaboration involving from community, the clinical kesihatan, GPs, as well as hospitals. And in Selangor right now, Hospital Shah Alam is our main diagnostic center. We are inviting other hospitals on board for REBUNG 2.0. So Hospital Beacon has been giving us the services of the LPPKN mammogram vouchers. We have a back-end communication with KK Taman Medan where the screening actually is ordered from the KK itself. So part of REBUNG is really creating the optimal care pathway where we actually educate people on how to obtain screening services in the case itself. And we provide information to patients through community navigators to how a diagnosis is made. So in REBUNG 2.0, as mentioned, we are now in a second pilot site. You can see all our collaborators. We have involved many government organizations, cancer NGOs, as well as community NGOs in putting forward the agenda of cancer early diagnosis. We are endowed with multiple grants, mainly from University of Malaya, Majlis Bandaran Petaling Jaya, and we even have the International UICC Breast Cancer Early Diagnosis Grant. Okay. So really, I do not want to go too much into this, but essentially what we hope to achieve through this collaboration, and especially through our primary care providers, where we are looking more into communicating very closely with our colleagues from MMA. Thank you, Dr. Siva, for being very kind to us, and also FMSA, as well as the Protect Health and Cell Care groups, so that we can help together improve the health literacy on cancer diagnosis, so we can actually improve the care of the patients. So we do have other programs like the Rakan Pembimbing Cancer Community REBUNG, or Rakanku. It is a training program for community leaders as well as cancer NGOs on the navigation of patients towards early diagnosis. So we've started engagement with our cancer NGOs as well as the committee leaders in Kampung Cepaka, and we are going to specifically invite our clinics in this area so that they can be part of the cancer optimal care pathway. And of course, we have also other courses that you will hear about. Our nurses, the committee nurse course for committee nurses for breast cancer, as well as committee training for cervical cancer. So throughout this collaboration, we hope that we will give input into the implementation of the Ministry of Health policies, and it will give a platform for all of us to work together for a similar goal of improving cancer early diagnosis. And today, I think we brought out two very important topics, which is lung as well as prostate cancer. There's many controversies with screening. We hope that we can address some issues today, and we can certainly address those issues when participate in the primary care cancer course that Dr. Suniza will be talking about at the end of the day. So thank you so much, Hanis. I'll pass over the mic to you. Later we can take questions at the end. Thank you.
Thank you so much, Prof. Aisha, for the thorough introduction on REBUNG Project 2.0. So now let's begin our discussion. Let me introduce our esteemed speakers and also moderators for today's panel discussion. The first speaker is Dr. Teo Ying as our case presenter. She obtained her Master of Surgery from UM and completed her fellowship in breast oncoplastic in Taiwan. Currently, she is the consultant in breast oncoplastic surgery in UM. She is a keen educator in creating awareness in breast cancer and actually one of our committee members of REBUNG Cancer Care. Next, I would like to introduce our moderator, Dr. Christine Shamala Salvaraj from Department of Primary Care Medicine, University Malaya, who attended her Master in Family Medicine from UM. She is the expert that is actually the closest to the community and actively involved in this REBUNG Cancer Care in Primary Care project. So the expert of panelists for today's discussion, we have Dr. Ahmad Nazran and also Prof. Pang. So Dr. Ahmad Nazran will discuss regarding early detection of prostate cancer. He is graduated from University of Manchester, UK, and currently one of our urologists in University Malaya Medical Center. He has multiple publications on genitourinary tract cancers, including the journal article on predictive factor on prostate cancer diagnosis with PSA. The other panelist is Prof. Pang, who will discuss regarding early detection of lung cancer. He is a respiratory physician in Department of Medicine, University Malaya. He is also an active speaker and also project researcher in early cancer diagnosis care among the community under REBUNG project as well, and also under UM Care. So I would like to welcome Dr. Teo to share a few case discussion, our moderator, Dr. Christine, and also our expert speakers, Dr. Ahmad Nazran and also Prof. Pang. Please welcome.
Thank you very much, Hanis. Let me share my slide. Right. Is the slide visible to everyone?
Yes. Yes.
Okay.
Slides.
All right. Sorry for the technical issues, a bit laggy. All right. Okay, so we will start the first case. Is that okay, Dr. Christine? Right.
Yes,
So
yes, Dr. Teo, please carry on.
all right. So this first case is we are talking about the early detection in prostate cancer first. So a short case presentation prepared by Dr. Ahmad himself. So he has a 69 years old gentleman now, came in to him asking about a PSA test. Okay. Right. On further history and examination, we found out that he has no lower urinary tract symptoms. He has no family history of prostate cancer. And he has a past surgical history of an open bladder stone surgery done 5 years ago. He is, however, a non-smoker, and examination shows it was a remarkable one. And the digital rectal examination showed that the prostate is not even enlarged and is smooth. Now, back to the questions that he posed to Dr. Ahmad, all right? Okay, whether to do the prostate-specific antigen test, PSA test, or not to do for him. So maybe I just open the floor back to Dr. Ahmad and Dr. Christine.
Okay, Assalamualaikum. Good evening, everyone. I'm Ahmad, one of the urologists from MC. So sometimes we get cases like this, So this patient, you see, does not have much symptoms. So this is a true screening case. So asymptomatic patient come in asking about PSA, and you can see he doesn't have much risk factors for prostate cancer either. So it comes in the end. Next slide, please, Dr. Teo. So you can see what the picture there, because in the end, the importance is of a shared decision making. So it's not really that you must do or you must not do. Okay, it's not Hamlet. Okay, so this one is we just have to discuss and see what do you think, because everything has the benefit but also have the risk. Okay, Of course, nowadays, to help us, you can also use certain risk calculators. So if anyone is interested, you can actually scan the QR code there and check your own or your patient's risk. Okay, so you can see here for this patient, although as I mentioned that he has not much risk apart from maybe ethnicity and age, but otherwise he has no family history, no LUTS, but his risk of having a finding a prostate cancer with further intervention is still considered average 11%. Okay, so it's not exactly low risk, which is the white thing at the side. Okay, so you have to discuss with the patient. Okay, what is the best thing to do? Okay, I pass back to you.
Right.
Dr.
We shall continue then. So we decided to just offer him the PSA as required. And the PSA result came back as 6.5. So what are we going to do next?
Okay, so as I said, have to discuss with the patient. Okay, so what do the guidelines say? Again, the guidelines say also about risk adapted strategy as well as shared decision making. That's the key word from the European Assistant Urology guidelines. So actually, for this kind of PSA, we know red flags, no worrying examination findings. Actually, most of as far as our guidelines say that we can actually just repeat. So that's what we did for this patient. Okay, so next slide.
So you repeated again, the PSA now is slightly higher than before, it's 6.68. Can I just ask the question that how long after the first test that you repeated this?
Normally, the half-life of PSA is about 5 to 7 days. So normally, so that would be about, at least if you want to 5 half-life, will be about a month. But most of the time, we repeat after 2 to 3 months. So the question back to me, this is probably when I set my own questions. Okay, so the thing is,
Yeah.
again, you have repeated is still high. So normally at this point, you have several options. Okay, so one option, again, some patients may not want to do further biopsy. Some persons may opt for biopsy. Okay, or in nowadays, if your center is available, we do something called the MRI scan. Okay, because this reading is actually in 2010. Okay, so this is about 13 years ago. Yeah, so at that time, MRI was not in the guidelines. So what he did next was the biopsy. Okay, back to you, Dr. Teo.
Right. Before I move on, if I'm allowed to ask, maybe for the interest of the audience as well, I understand that the PSA rates sometimes differ from different age group. So is this considered as a high normal, or slightly high?
Okay, the question is a good question, Dr. Teo. The question is how high is high and how low is low. Okay, because as you know, as you correctly mentioned, that for anyone as increasing age, the PSA tends to be higher. But just to give a ballpark figure, so for something, the normal cutoff that we take, although this is a very arbitrary cutoff, is a PSA of 4. So if you were to take a PSA of less than of 3 to 4, even though it's supposed to be normal, the risk of prostate cancer is 26.9%. Okay, that is not something to sniff at. But the other interesting to point that later we'll talk a bit, the risk of clinically significant prostate cancer is low, is 6.7%. Okay, so this figure, of course, you expect it to go a bit higher. So not risk of prostate cancer, maybe about 30%, we are clinical significant about 8%. Okay, but again, all these are percentages. So if we have patients even with a PSA of 0.1, the risk of prostate cancer is 6.6%. So it's actually no real cutoff figure, just that we use 4 as an arbitrary cutoff so that we don't investigate patients.
Okay, I think we just move on with the case first, probably a few more questions later. All right, so I think you mentioned about biopsy to this patient. Right, so this biopsy came back as, the transrectal ultrasound guided biopsy revealed an atypical cells. So you have decided to biopsy again this prostate, which shows no malignancy. But somehow patient has complication of severe bleeding requiring admission. So let's move on to the discussion. All right. Okay, what's your take on this decision for the biopsy?
So I said, I say biopsy is part of our armamentarium, but the thing to say is that why we say that we don't want to, simply screen every single patient is that the complications are there. Of course, the complication of bleeding, in the literature is less than 5%. In our own center is about 1%, but you cannot say there is no risk. So that's why the importance of discussion before we do, because it's not a test without complications. That's what I want to say.
All right.
Dr. Teo and Dr. Ahmad, would you like to take some questions, or would you like to complete the scenario first?
Maybe we complete first, then we take
Shall we?
a
We complete
Sure.
first?
much longer.
All right. Okay,
This
so
one you can see. So the PSA, no need to tell you the number, you can see it's steadily rising. But because he has been become like almost phobic of another test because of the severe bleeding, that up to the PSA go up to 40 something, he was still very reluctant to go for further biopsy. Okay.
okay. So what happened finally is that you offered an MRI, proceed to the patient, and this was reported as a PRATS 5 lesion. So I think probably you would like to explain more on that PRATS, and further trust biopsy done. Maybe on this part, the cognitive fusion, maybe you can explain a little bit further, because as far as I know, there's a knee trust biopsy and the Gleason score, which is a total of that 2 samples, the highest score, right? So this is 4 + 4, prostate cancer was confirmed. And he was offered a bone scan as well as a CT scan, which diagnosed that he has no distant metastasis. And subsequently, he was treated with an LH-RH agonist and external beam radiotherapy in the year 2021. And so far he's keeping well. And the current latest PSA level is 2.03, which I think is normal.
So what I want to highlight from this is that once you do that first PSA test, you're actually starting the patient on a journey. Okay, it's a journey, because once you start, you cannot get out. Okay, so even though the first 2 biopsy no cancer, so you can see that in the end he still has to do repeated tests, has to come anxiety, got the complications of the biopsy as well, which didn't help. So you have to, that's why we don't condone blanket population screening for prostate cancer at the moment. MRI is similar. What the PIRATS, it just means the grading of MRI. So PIRATS 5 is similar to PIRATS 5. We borrowed it from there basically, but it's basically the most highest risk of cancer can go up to 80% depending on where you read. Okay, so trust biopsy, cognitive fusion, just a nice way to see that. Nice way to say that you saw the MRI and then you biopsy based on the MRI using your own cognition to tell you what the thing is. Of course, there are newer technology where you have inline fusion, but that's not the topic of today's presentation. Okay, but the good thing is that despite the potential delay, so you can see that this was 2010 and this is 2023 now and treated 2021. But the good thing is that there was no real adverse event and we still actually treated with the aim of cure for this patient.
Okay, I think the next slide is your summary. Would you like to summarize first, Ahmad? Then we'll take some questions.
Yeah, I think basically what I said, that it's not something to start straight away without discussing with the patient first about the risk and benefit. Okay, and of course there are things that can help you, risk calculators, MRI, whatnot. Okay, but I think one thing that will help is programs such as REBUNG to increase the awareness. Then hopefully people can make more informed decisions.
Okay, so thank you very much, Dr. Ahmad. Probably I'll just hand over this floor back to the moderator, Dr. Christine, to answer several Q&As.
Thank you very much, Dr. Teo and Dr. Ahmad, for discussing about what looks like a very typical case, which is something we may encounter in our clinical setting. So essentially what you've told us, Dr. Ahmad, is that when it comes to counseling a patient for prostate cancer, it's not just a straightforward process. You do need to have a detailed discussion with your patient about what are the possible outcomes of investigation. And once you start investigating, there's no turning back, isn't it? So let's take a few questions. So we have some in the chat box here with regards to sampling of PSA. Shall we reschedule the time for PSA sampling, perhaps after a DRE, digital rectal examination? I suppose the PSA will slightly increase.
Okay, I mean that's a good question, but normally the increase is not much. It's only about 15%. So if you have somebody with already you feel it's a nodular prostate cancer, you're quite suspicious. Doing the PSA immediately is not going to make much difference. Okay, but if you find a standard patient, then as I said, the half-life is about 5 to 7 days. So you can do the PSA after, about 2 to 3 months should be fine.
Okay. Thank you, Dr. Ahmad. So that also answers the next question. Should we take blood for PSA prior to the DRE?
The thing is that when you see the patient first, normally we take the history and examination first. Okay, I mean, that's a normal practice.
Yes.
So then, because sometimes once you feel something in the prostate, then it's no longer a topic of screening anymore. It actually shifts to diagnosis. So your intent of treatment is completely different. So I would still go by our standard method of history examination and investigation.
Okay. We have another question here. Should we act upon an incidental finding of prostate calcification on ultrasound KUB and prostate?
Okay. So actually there's no correlation. Unlike like breast cancer or thyroid cancer, there's no correlation between calcification on detector ultrasound and prostate cancer. So I answer this, I wouldn't. Because more is an effect of chronic infection causing calcification.
Sure. Right. Then another statement from Dr. Hafiz, but we are highlighting the scenario with complications. There may be cases which early diagnosis may help.
Yeah, I mean, I agree with you completely, Hafiz, but I would say I don't have time to put different scenarios up. But yes, of course, there are cases, particularly where you can detect aggressive forms of prostate cancer, those with high Gleason score, where definitely diagnosis may help. But again, as you said, this is need to discuss with the patient. As you said, if we do a DRE, confirm they will be okay with PSA, but not necessarily so. Because I said once you do the PSA, it's like you're locked in that patient for your follow-up almost for life, So that's something to consider.
Exactly.
It's not necessary with the DRE.
Sure. Okay. In the interest of time, I think if we can take one more question here, Dr. Ahmad, maybe the next we can reply in the chat box, I suppose, if there are more questions that come in. So this question, how or what can we do in patients with high PSA, where the levels are noted to be rising periodically, and on repeated trusts, no significant findings were reported, referred to urology? We have a visiting urologist from Hospital X. How or what else can we do to allay their anxiety and fears?
That's a very pertinent question because it's similar to what happened to this patient. Nowadays, we have an MRI, and the key thing about MRI is that it can help increase the sensitivity. One is to increase the sensitivity of the biopsy, but also to reduce the detection of non-significant prostate cancer, which is usually what you say the Gleason 3+3. Okay, so that's why MRI nowadays is incorporated before trust biopsy. Okay, that's in the last 4 or 5 years. So, but as I said, it's very difficult because even if you do that, it may come back as negative. But that is the thing, because sometimes they do the test without knowing how much anxiety and fear it can cause.
Yes.
And this is why, and as going down to the question of Ikhwan, that is one of the main key points that you need to highlight. One is of course the benefit of early diagnosis, treatment and cure, but you also need to look at the other side, the problem of anxiety, fear, complications of biopsy.
Right. And I think I'm not too sure about the availability of this MRI facilities within the country.
That's the thing. I mean, MRI, a lot of government centers have, but to have the 3 Tesla MRI to do the multiparametric prostate, not every center has. Yeah, I mean, we're fortunate UMMC has one, but not every center I think what the centers, I think, I'm not sure then HKR also has. Okay, of course there's an alternative. You can still use the 1.5 Tesla with the vector coil, okay, to improve the uptake. But as I said, that's one of the reasons why we cannot use MRI as a screening tool, even though there is a recent study that actually supporting that, because it's just not logistically available, possible in our country at the moment.
Yeah, it's also not going to help our patients' anxieties, you know, in the time frame within between these investigations.
Just sitting in the MRI can cause anxiety, I think. Yeah.
Okay. Thanks so much, Dr. Ahmad, for your for sharing your insights here. Dr. Teo, shall we carry on?
We'll be sharing the next slide. So we would like to welcome Prof. Pang today. Sorry, are you seeing the slide of the lung cancer now?
Yes, we can
Yes.
see your slides.
All right, just one. I think on my side, I'm not seeing. Stop sharing again and share now.
Yes.
Okay, I think I'm not seeing myself on the screen. Okay. All right, so am I in the presentation mode now?
No, you are still not in the
not yet.
presentation.
Now,
Okay,
yes?
yes. Now you are.
Yes.
Yes.
Okay, great. Okay, so I'll just take you through a very short case, all right? And we will actually like to highlight on the early detection of lung cancer instead of screening. All right, so we have Mr. G here. He's a 56 years old hawker. Well, he works as a hawker. He presents to the clinic with shortness of breath for almost 1 week. And he complains that he has been coughing since the past 1 year. However, there was no hemoptysis, and usually it was a dry cough. So his wife noticed that he is actually losing weight over the past 1 year. For the past 3 months, he also complains of severe low back pain, which he needs on regular analgesia. And on further past social history, actually, we noticed that he has been smoking since he was 20 years old, at least 1 pack per day. So when you see this kind of patient in your clinic, what would be your approach to this kind of case? All right, I'll pass this to Prof. Pang for further discussion.
Okay, so shall we go back to the first slide? All right, yeah, lung cancer, as you know, is one of the commonest cancer among the male patient. I think it's only second to the colorectal cancer. And then among the female, I think it's the third commonest cancer in Malaysia now. But in terms of mortality, it is still the highest among all the cancer in Malaysia, partly because many of these lung cancer patients, when they are diagnosed, is in their very advanced stage. Most of the time, I think they are in stage 4, and some in stage 3, but even in stage 3 also, a lot of them in stage 3B, 3C, and very few of them, I would say, maybe 5%. In stage 1 and 2. So majority of them are not amenable for curative intervention like surgery. So that's the reason why we are highlighting this case over here to show that lung cancer, I think, I think screening for early stage of lung cancer is another talk altogether. But what I would like to highlight today is more like identifying lung cancer early in their presentation. So you can see that many of these patients have been coughing for a long period of time. But unfortunately, many of them, the diagnosis was not being made. And either from the patient perspective, because most of them, they like to brush it off and think that, wow, this is the result of my smoking. Or sometimes from the healthcare providers, because also we have the same mentality, well, it could be actually because of the smoking behavior. But the telltale sign over here is that sometimes even if they are coughing because of the smoking, so we have to explore a bit further in terms of the nature of the cough. You see, so if it's due to lung cancer and if it's big enough, usually the patient would have a change in terms of the character of cough. The cough might be actually much more severe, more frequent, and also sometimes they may be associated with some more sputum production. And occasionally you encounter patients with hemoptysis, which is probably about 20% of them. So even if they do not have the warning sign like hemoptysis, I think it's always still advisable try to explore a bit further to see whether this cough is due to COPD, asthma, the common causes, or things like lung cancer, because lung cancer is quite common among the smokers, those who are, especially those who are above 40, 50 years old. And then the other warning sign over here is losing weight. For COPD, we wouldn't expect the patient to lose weight. So losing weight is a very significant symptoms. We should always pick this up. Of course, a lot of these patients can't really quantify how much weight they lose. So yeah, while we go back to what we teach the medical students in school, well, if they have significant weight loss, like let's say for men, if they are wearing the belt, one buckle is about 1 inch. 1 inch in an average male adults of 60 kilo. My personal observation is that it's easily 2 to 3 kilo, if not more. So that's how I estimate. Of course, our throughout our life, weight may fluctuate as well, right? Maybe, but usually not more than 1 to 2 kilo. If the patient are telling you that if they lost significant weight, something noticeable by someone, that means it's already more than 2 to 3 kilos. Usually, losing 1 or 2 kilos is not so noticeable. When it's noticeable, especially by the spouse or friends, I think we have to take this more seriously. All right, then the next slide. Okay. So of course, we will advise anyone who have a chronic cough for more than unusual chronic cough for more than 2 weeks to have a chest X-ray done. The reason is very simple, because lungs, they are actually the big organs, and then they are like the sponge, you know, it's not like the solid structure. So usually the chest examination, we are trying to pick up telltale sign from outside. And some of these, let's say the mass lesion will not demonstrate any signs at all. So even the physical examination is normal. We should still do an X-ray, because the advantage of doing an X-ray is that you can see through the chest, right? And also because lung is a spongy organ, it will create an ideal contrast to any solid structure. So you can see that mass elsewhere, let's say abdomen or some other organs, chest X-ray is not very useful. Whereas for lung cancer, chest X-ray is very useful because lung is a spongy organ, and most of the time when it is normal, it will appear quite black. So any solid lesion will stand out. So any lesion more than 1 to 2 centimeters usually is quite visible on chest X-ray. The other caution is that about 5 to 10% of the cancer might be located in the central airway or mediastinum. So a normal X-ray does not always exclude the presence of lung cancer. So this patient already have like low back pain, so we can expect that this patient could have metastasis to the spine. So so this is a very brief highlights. So this patient, an X-ray done, you can see mass was found, and you can see this is obviously a huge mass. because the patient has been coughing for 1 year. And then with a spine metastasis, I think the staging is going to be stage 4. So although this tumor looks like it's resectable, but because of the distant metastasis, it's no longer resectable. So this patient is having stage 4. So the highlight is that any symptomatic patient, I think we should investigate them early. So then some of you might want to ask about that low dose CT scan screening. That is actually a slightly different approach. That is actually to screen for patients who are at higher risk of developing lung cancer. So meaning that they're screening the general population who are high risk. So that is a totally different approach. This case that we are sharing over here is mainly to highlight that we need to have a low index of suspicion, and then so that we can diagnose the patient early and the patient would have better chance of survival. Okay, that's all I'd like to share. Thank you very much for listening.
Thanks, Prof. But just to backtrack a little bit, if let's say this patient comes to us, would you actually agree that if I send this patient for a TB workup as well? Because patient is losing weight and is coughing, it's dry cough. Yeah. And before that, the Xray was done.
Yeah, TB is definitely one of the differential, and TB is still quite common in this country. So I would suggest the same. Anyone with chronic cough, unusual cough for more than 2 weeks, you should perform a chest X-ray to see not just for lung cancer. Of course, the topic for discussion today is lung cancer, but another common diagnosis that we may pick up is pulmonary tuberculosis. TB is still actually the top #1 killer as a single infectious disease. So a lot of people are not aware that TB is still the top #1 killer, because every year we lose between 500 to 1,000 individuals to TB. So that makes TB the top #1 killer for infectious disease. So that is another important thing. So you kill many birds with one stone, right? You pick up lung cancer, pick up the TB, or sometimes you may see the hyperinflated lung, then you pick up COPD, right? Or asthma, or sometimes you pick up like chronic cough. Maybe the patient is having bronchitis, for instance, or occasionally you pick up interstitial lung disease, although it's not that common. All these changes are visible on chest X-ray.
Thanks, Prof. Over to you, Chrissy.
Thank you very much, Prof. Pang and Dr. Teo. We have a few minutes for some questions here, Prof. So if I may. Okay, we have one question here. After so many years, is there any blood test to screen for lung cancer?
Well, unfortunately, blood test is not a very sensitive way of identifying lung cancer. Nowadays, the tests are quite sensitive to pick up the biomarkers, but then we still need the histology to give us a confident diagnosis of lung cancer. But there are already many plasma testing after the diagnosis is made to further identify the types of the biomarkers, because the treatment is, I must say that it's quite complex these days, because you need to identify specific markers, and when you are able to identify the specific markers and they are available therapy for that specific markers, you can better target the lesion. And sometimes the response rate is a lot better. Good response rate does not translate to long-term survival, but then they survive much longer than what the lung cancer patients used to survive. Average lifespan in the past without any treatment was 3 to 6 months, and those with treatment probably the average lifespan is about one year for chemotherapy. But we have patients now with specific biomarkers and being targeted with the appropriate therapy that survive very long. I think nowadays maybe 3 to 4 years is not a dream anymore. And then of course we have exceptional patient who responded so well, and then they keep responding to first line, second, third line therapy. So we have patients who had stage 4 lung cancer but survived more than 10 years.
That sounds very reassuring.
Yes, so I think it's always good to identify them early, because in the past, the general perception is that, well, even if you identify them early, so what? You do not have good treatment for them. But the landscape has changed dramatically over the last 10 to 15 years.
All right. Okay, thank you, Prof. Another question. This is regarding the use of CT. What is your opinion on lung cancer screening among high-risk population using LDCT in our country?
Okay, yeah, thanks for asking these questions. I know a lot of people are quite interested on this low-dose CT scan. So, but if you ask me what is the evidence behind, there is evidence behind to support low-dose CT scan in the population for high-risk individual. So what we meant by high-risk individual means that they are above 40 years old, 30 pack year of smoking, and this is actually being demonstrated by two big landmark study. One is the one done in United States, the lung cancer screening, the so-called the National Lung Screening Trial, whereby in this trial they will manage to show a 20% reduction in mortality for lung cancer death. And then for the Nelson study, predominantly done in Europe, a 24% reduction in mortality was observed. But then, in order to do this kind of screening, it's not as easy as what, like, okay, subject them for low-dose CT scan. Because many of the times you pick up a lot of other noise, so-called some nodules, especially TB is still endemic in this country. So the question is, would you act on this nodule? And also sometimes the prostate cancer screening, you see. So when you identify some abnormal CT scan, then the patient becomes super anxious. So you need to spend adequate time counseling them. And then you need to guide them to the diagnosis, whether this is a significant nodule, insignificant nodules, whether you need to act on it now. And if you need to act on it now, what kind of intervention do you require, or you just repeat the scan in 6 months' time or 3 months' time? So a lot of this kind of issue that we need to address. And then the other thing is talking about the availability of the facilities, and then the competency of the people who are reporting on the CT scan, because there are medical legal issues involved, right? So the counseling, the consent taking, all this will take time, actually a substantial time. So it's not to be underestimated. Evidence is there, but we have to do it properly. So meaning that in the US study, for instance, put it this way, I think the study was done like they had the 3 low-dose CT scan done during the trial period 0, 1, and 2. And then the median follow-up is 6.5 years for those who participated in their trial. So put it in a very simple perspective, for 1,000 patients who participated in that trial, ultimately, at the end of the trial, 41 patients were diagnosed to have lung cancer. Yeah. So it's not a very high percentage. So we need to be mindful that only 3 to 4% of the patients were eventually diagnosed. But for the patients who are diagnosed, of course, their life can be transformed, because from a non-curative disease, they are offered a cure, potential cure.
Thank you very much, Prof. Pang, for sharing your experiences and insights here. We still have a few questions in the chat box. Unfortunately, time is not on our side today. Would it be possible if we could answer some of these questions in the chat box directly?
No problem. I'll answer the
Sure.
chat box.
Thank you so much, Prof. Pang, Dr. Ahmad.
You're most welcome.
You. Thank you.
Yeah, thank you very much.
Thank you. Dr. Hanis, I would like to hand the platform back to you.
Thank you so much, Dr. Christine. Thank you to all the expert panel for a very interesting discussion. So hopefully we are now more aware of the importance of early cancer screening and also detection and how we should do about it. So last but not least, I would like to invite the pillar of our program, the course director of REBUNG Cancer Care in Primary Care short course, Dr. Suniza Jamaris, to officiate the soft launch REBUNG Cancer Care in Primary Care short course. Dr. Suniza is a consultant breast oncoplastic surgeon in University Malaya and has been elected as representative of Greater Petaling for the leadership program for women in oncology under City Cancer Challenge Foundation. So please welcome Dr. Suniza.
Assalamualaikum warahmatullahi wabarakatuh and very good evening. Thank you very much, Hanis, for very kind introduction. So this is the main thing that why we would like to have this soft launch for cancer care in primary care short course for today. And I'm the course director on behalf of the UMMC Education Group. I would like to thank to all these our collaborators here. You can see MMA, AFPM, FMSA, PKB 40 and University Malaya itself, who had tremendously given a support in order to ensure that this cancer in primary care short course in success. So as far as we concern and from what have been discussed earlier, Malaysia has low survival rates for most cancer despite of having universal coverage. And this is because of most of our patients presented late at stage 3 and stage 4. Why is this thing happening? Because of poor literacy, low income, and psychosocial cultural issues. So as reported by our recent National Cancer Registry in 2012 to 2016, almost half of our patients presented late at stage 3 and 4. Okay, and early diagnosis, you know, as can best define as the timely resolution of diagnosis in a patients with symptoms of cancer. And this has been recommended by the WHO as an important cancer control strategy for especially a country like us without organizing screening. So what is the early diagnosis of cancer shows a better survival outcome with a better experience of care and lower morbidity from cancer treatment. As you know, the higher the stage, the more complex in terms of treatment. And last but not least, the early diagnosis can significantly improve quality of life. And how are we going to achieve this is basically one promising strategy to improve this timely diagnosis is to train our community-based general practitioners or primary care providers out there who on how to detect cancers as early as they are, because early as they are closer to the community. And one of as we know that the COVID-19 has changed the way education and medical services are being delivered. And previously, most of us will go for the face-to-face session, but during the COVID-19 pandemic, most of us have changed towards online training. So according to the World Economic Forum, the need for online learning and resources has tremendously increased due to the COVID-19 pandemic. And because of this, I think we choose as online training for all our busy GP out there to promote learning and information retention. And most importantly, it requires less time compared to conventional face-to-face learning. And this is study that we have done earlier, REBUNG 1.0. We already developed the most Malaysia 5 most prevalent cancers, which is breast cancer, colorectal cancer, lung cancer, cervical cancer, and also prostate cancer training program. And the aim is to improve primary care provider cancer screening as well as early diagnosis literacy. So with that, we also would like to evaluate whether this online training is relevant and effectiveness for our general practitioner out there. We already done last year, and then it's quite promising, and most of our participants given a very excellent feedback towards our short course. And as you can see here, this cancer care in primary care short course, we have a development team comprised of 30 professionals specialized in cancer care. Okay, there were 5 phases of development, as you can see from these slides, and there were the learning objective was developed, and a content matrix was designed in order to ensure the learning objective were embedded within each cancer module. Okay, we use the Gagnier 9-step model of adult instructional design, as well as a Kirkpatrick model. So once the module developed, we upload into open learning, which is full online training, and also we did a pilot testing in Taman Medan area. And this is, as you can see here, how the cancer care in primary care short course will be done. I mean, we will be scheduled as we will start with the Project Eco introduction on the 15th of March. And we will introduce and we will teach the participant how to go about this open learning, all the in terms of like technical issue. And then subsequently on the same week, we start with the breast cancer, followed by colorectal cancer, and so on and so forth. And the best thing of this cancer care in primary care short course, we do have a case discussion as what we have today, and it's quite interesting, and a lot of questions come up during this closing event. And all the participants can have whoever, I mean, whichever participant has any cases to be discussed during the closing event, you can do so. We actually encourage them to have a case discussion with the expert panel. And you can see here, this is very busy slides, and left-hand side, there is a training module and the learning objective. And each module, there will be a sub-module in it, and also there's a learning objective. So we start on the 15th and we will end on the 24th of May. It's supposed to be 7 modules, 7 weeks, but we extend another 3 more weeks, you know, to give some time for you to do the online training. It's basically a self-study using the open learning platform. This is how the open learning platform looks like. All right. So when you enter the open learning short course, when you access the cancer care in primary short course, you will start with pre-course assessment. You want to know the baseline of your knowledge. And then subsequently, we will start with the module 1, breast cancer. Okay, and you can see here, there is, in one module, there is a lot, there is a sub-module down there with the module feedback at the end of the module itself. For example, like breast cancer, so there will be a module feedback for each at the end of the module. And this what we call that module is very interesting. Why? Because there is a reading materials for you to learn, and also there is a lot of case scenario as well. And we also learn how to screen and manage a patient. You see, this is how it looks like. And there will be a self-assessment quizzes, you know, after your reading, after you reading all the materials that given. And also there is also match, for example, as what you can see here is a breast cancer, this mammogram category, Barrett's classification, and what are the management, and you can see if you can get correct, then it will just show you that is correct. So it's quite interesting, I suppose. And but you will be facilitated by the expert panels. And if you have any question, as what we can see in our chat box, asking whether the tumor marker is important, whether it's helpful in terms of cancer screening or not, this all in the cancer in primary care short course can answer all this. So why not you join us? And then this is how you see our introduction, starting from we have a project EcoZoom, and the closing event, everyone happy, smile face. And this is not only the participant, but as well as the expert panels. Okay. And at the end of this course, you'll be awarded 20 CPD points by the MMA. And for the free registration is for the clinic under REBUNG study, which is under this postcode 47301. However, if you would like to join, whoever that outside the REBUNG study, you have to, this course itself value about 1,400, but we just, charge you very cheap, about 200 for early bird, and 250 after the 10th of March. And if let's say you just want to have one module, for example, you need to pay about 50 ringgit per module. I think that's the end of my presentation, and I hope whoever would like to join, you can scan here to register, and then there will be a 20 CPD point, and you also be rewarded about a certificate at the end of this course. All right, I think I end my presentation with thank you, and please join us in a REBUNG Cancer Care in Primary Care short course.